Now I request Dr. Divya Alex to present the next talk, Ready Reckoner on wet AMD, RAP and PCV.
This one. Good morning, everyone. So, when a patient presents to you with this kind of clinical picture, you can possibly give some professional diagnosis, whether it is wet AMD, the type 1, 2, or 3, or it is the other end of the spectrum, the polypoidal choroidal vasculopathy. So, I am going to take you through some imaging clues to arrive you at the final diagnosis. So, the wet AMD, the hallmark of the disease itself is the choroidal neovascular membrane. Excuse me, pointer, please. No, in this, it's not coming. It's not. See, the hallmark of the disease itself is the choroidal neovascular membrane. So this is the classic case where you can see the deep subretinal greenish-gray membrane with a surrounding neurosensory detachment and the tinge of hemorrhage just surrounding it. This is the classic presentation, but there can be different kinds of presentation like multi-level of bleeding. Multi-level of bleeding, there can be sub-RP bleeding, subretinal bleeding. It can be associated with soft confluent drusen, lipid exudation, or there can be massive subretinal hemorrhage. So this is the type 1 or the occult CNV, where the neovascular membrane is located below the retinal pigment epithelium. So this is the most common type, and in the OCT we identify this as a fibrovascular PED. You can see multiple moderate level of hyperreflectivity between the retinal pigment epithelium and the Brooks membrane. So the exudation usually associated with the occult will be subretinal fluid. Whereas in the type 2, the classic, the choroidal neovascular membrane will be located above the retinal pigment epithelium. That is, it is subretinal. And the classic OCT finding will be the SHRM or the subretinal hyperreflective material seen. And the usual exudative pattern associated with the classic CNV will be a combination of the intraretinal as well as the subretinal fluid. So once you get the intraretinal fluid, the disease course is going to be more aggressive. That is, the subretinal fluid is less clinically aggressive than the intraretinal fluid. And unlike the classic CNV, the occult CNVM has got a less aggressive natural cause based on the presenting acuities as well as the long-term natural history. And you can also get the type 4. Type 4, it is the combination of type 1 and type 2, where you can see the fibrovascular PED as well as the subretinal hyperreflective material. You can see a combination of type 1 as well as the type 2. So the fundus fluorescein angiography usually helps in detecting or differentiating between the type 1 and the type 2. So in the occult, as there is the sub-RP fibrovascular PED, there will be always a stippled hyperfluorescence, the early stippled hyperfluorescence with pooling either with or without leakage during the late phase. Or there is another presentation that is late leakage of an undetermined source, that is LLUS, often presenting as a speckled hyperfluorescence with subretinal pooling of the dye. But the second type, the classic, it is entirely different from that of the type 1. You can see an early lacy pattern and it will be clearly well demarcated margin, increasing in intensity with leakage during the mid and the late phases. So these were the signs of active disease. So you should also know about the signs of chronicity. One sign being the scar. That is, instead of that moderate hyperreflectivity, you can see entirely different type of uniform hyperreflectivity that is called as the scar. And next one is the outer retinal tubulation, and next is the geographic atrophy. So this is the picture of geographic atrophy. You can see there is complete loss of the outer retinal layers. You cannot see the ellipsoid, you cannot see the photoreceptors or the RPE with the reverse shadowing. This is the geographic atrophy, and this is what is called as the outer retinal tubulation. This is the chronic inflammation photoreceptor rearrangement. So you can see a hyperreflective lumen surrounded by a hyperreflective lumen. That is, this should be differentiated from the hyperreflective intraretinal cystic spaces. That is, this will be purely hypo, and in this you can see a hyperreflective lumen. So the outer retinal tubulation, it is a sign of chronicity. And this is the type 3 CNVM, the retinal angiomatous proliferant. And this goes through, this is a distinct form of focal CNVM associated with proliferation of intraretinal capillaries, and this goes through a 3-stage vasogenic sequence. So this is the stage 1 where there is intraretinal neovascularization, and this is a capillary proliferation arising from the deep capillary plexus, and in the stage 2 this further grows and this causes a retinoretinal anastomosis, and in the stage 3 this further grows below the RPE and it forms a retinochoroidal anastomosis. And there are certain classic features of classic OCT features of ROP, the trapezoid PED, the wrinkling of the pigment epithelial detachment, which is associated with intraretinal fluid, and this is the erosion sign. That is where you trace this pigment epithelial detachment, you can see a portion, it is eroded, and there will be a hyperreflective material just above this erosion. This is called as an erosion sign. And you can see these 2 free flaps of the RP that is broken. This is called as a free flap sign, and it will be usually associated with reticular pseudodrusen. So the reticular pseudodrusen, unlike the other drusen, it will be above the RP. And whenever you see other eye reticular pseudodrusen, you should also think about the possible diagnosis of RAP. So here we were talking about the thin choroid spectrum, that is the wet AMD. So this is the normal choroidal thickness. This is the thin choroid with wet AMD, and now we are going to talk about the thick choroid, that is the pachychoroid disorders. So the polypoidal choroidal vasculopathy was first described by Yanusi et al. In 1982. It was a clinical entity distinctive from neovascular AMD, consisting of peculiar subretinal polypoidal vascular lesion with serous and hemorrhagic PEDs. So the classic feature of the PCV is that you can see a thick choroid, and these are the pachy vessels, and the pachy vessels compressing the choriocapillaries. So it can emerge as a hemorrhagic disease or an exudative disease or a combination of both. And there are certain classic OCT features in PCV also, that is the tall peak PED, the thumb PED, the notch, the PED, the tomographic notch. All this presents as a polypoidal lesion inside this RP. And there can be, the another distinctive feature is the presence of BVN, that is the branching vascular network, which will be seen in the OCT as the double layer sign. You can see there is the retinal pigment epithelium and the Brooks membrane, and in between there is a hyperreflective substance lying between this. So this is the double layer sign, which signifies the branching vascular network. Me and my professors were very lucky to elaborate one distinguishable sign in the polypoidal choroidal vasculopathy, that is the lateral elongation of the flat irregular pigment epithelial detachment. So we described the evolution of the disease through this. So this was the flat irregular PED, and this is a quiescent disease, and once it starts elongating, slowly the disease is starting with the formation of subretinal fluid and IRF, and you can see at the end of this there is the formation of polyp. So this is the quiescent disease, and after a period of time the polyp is developing at the end of the elongated flat irregular PED. So as fundus fluorescein angiography helps in the type 1 and type 2 FFA, ICG lots helps in diagnosing the PCV as well as the type 3 RAP. So the classic features will be early nodular hyperfluorescence arising from the choroidal circulation arising in the first 6 minutes, and the branching vascular network appearing within the first minute of dye injection. And the ICG in the RAP, and you will be seeing a hotspot at the center of the PED, whereas in PCV it will be usually at the edge of the PED. So the talk will not be completed without the OCT angiography. So these are the different types of pattern that you can get in wet AMD, that is the Medusa head, whereas there's a central feeder vessel and centrifugal vascular trunk, and the C-trunk pattern with an eccentric feeder vessel. So usually the type 1 lesions are larger and less demarcated compared to the type 2 lesions because they are sub-RPE. Type 2 CNVM usually smaller and they have a glomerular appearance, and higher flow indexes will be usually associated with the type 2 or the classic CNVM. And OCTA in RAP, it is usually dictate the retinal anastomosis from DCP very clearly. And the tuft-shaped high-flow network will also be seen even in the B scan as well as in the OCT angiography. So in PCV, the octa, you should be knowing that ICG delineates the polyps better, but OCTA will delineate the BVN better. So these are the diagnostic clues which help in demarcating these three diseases. So thank you once again the KSOS and scientific committee for this.